Hello, my name is Jessica Pierce, and I will be presenting on improving patient care documentation in a college athletic training setting. For this initiative, our QI team's focus was centered on improving patient care documentation. Patient care documentation is the official and legal record of the care provided to a patient and should occur at any time a healthcare provider has a patient encounter. It is required by federal and state regulations, by our National Association standards, and by third-party payers if a facility seeks reimbursement. Athletic trainers are medical health professionals and should be held to the same documentation standards as other professions such as physical therapists, physicians, and nurses. Domain 5 of the Board of Certification Practice Analysis states that athletic trainers require various criteria for documentation of patient care and treatment depending on the setting and state requirements. Using appropriate documentation, no matter the athletic training setting, permits meeting of state, professional, and ethical standards of practice. Inadequate documentation can lead to many issues for the athletic trainer, patient, employer, and even the profession. There are several benefits to maintaining proper patient care documentation, some of which include enhancing communication between providers, compliance with third-party reimbursement guidelines, and data collections for items such as staffing, injury rate, and budgeting. Although athletic trainers see the benefit in keeping accurate patient care documentations, several barriers have been noted. Those include time, employer expectation of documentation, accountability to document, not billing third-party payers, uncertainty of how and what to document, and not having the facilities or means to document, such as internet access or computers. As you'll see, our QI team attempted to address several of these issues in our setting. After noticing the issue of a lack of proper documentation, our goal became to increase the documentation of patient encounters recorded in the EMR compared to the previous year. We defined patient encounters as any athlete receiving treatment in the athletic training room. We defined treatment as any service rendered to the athlete, which included general treatments such as ice bag or hot pack, preventative, post-injury, and post-surgical rehabilitation, and recovery sessions. Our team included the Director of Sports Medicine, who is responsible for overall collaboration with the EMR Corporation and for setting expectations, guidelines, and accountability to the staff athletic trainers for employing proper documentation strategies. The Associate Director of Sports Medicine was responsible for collaborating with the EMR Corporation regarding athlete primary insurance and third-party reimbursement. The head football athletic trainer was responsible for collaborating with the EMR Corporation in regard to software and equipment maintenance and was also responsible for educating the AT staff on use of the kiosk login system. The entire athletic training staff was responsible for loading their respective teams' athletes into the biometric kiosk sign-in system, educating the athletes on how to sign in, reminding the athletes to sign in, and approving treatment sign-ins and entering daily notes into the EMR. The athletes were then responsible to remember to sign in at the end of each treatment session. Our process at that time looked like this. An athlete would enter the athletic training room, receive treatment, and then leave. The AT should then have gone back to his or her desk to log the treatment and daily notes into the EMR. If this pattern was followed, then great, the information was sent out for reimbursement by our EMR Corporation. However, we found that to happen too often is that the AT would have several athletes to treat at one time. When one athlete would leave, the AT was likely still working with one or multiple athletes, preventing him or her from going to their desk to immediately record the treatments and notes. Treatments that were conducted would have to be logged much later and rely on the memory of the athletic trainer after several hours. This makes it hard to remember everyone that the athletic trainer was working with and all treatments conducted. For example, maybe a short discussion and the athlete was given an ice bag versus a lengthy post-surgical rehab. A lot of the time the shorter treatment was not logged because the AT was more worried about remembering and logging the post-surgery treatment. Our main issue was lack of documentation of treatments performed in the athletic training room. Several factors were causing this dilemma. We had no way to enter treatments while working with multiple athletes without going back to our desk in the middle of another athlete's treatment. Working with multiple athletes combined with many other duties that athletic trainers performed during the day led to limited time for the athletic training staff to log treatments quickly. At that time, we did not have a system in place for athletes to sign in to treatment, which led to having to remember all the athletes that were seen during a day at a later time. Lack of equipment was also an issue. Desktop computers were the only means for the AT staff to log treatments, and there was nothing in place, digital or paper, to record athletes coming into the athletic training room. All of these issues tie into the fact that we were being non-compliant with the documentation standards set forth by federal and state regulations, the university, the National Association, and third-party reimbursement companies. From this information, we developed our aim statement. From March 2018 to January 2019, improved the number of treatments documented by 25% when compared to the previous year. We decided to measure our improvement by tracking the number of treatments logged into the EMR. This was done via a monthly report received from the EMR Corporation that identified treatment log tracking based on individual AT, sport, type of treatment, treatments per injury, and overall total treatments. For this project, we looked mostly at overall total treatments. Changes made to help improve number of log treatments included installing 2 kiosk sign-in stations near the athletic training room door so that athletes could sign in for treatment as they leave. There's only one entrance exit to the athletic training room, so they had no choice but to pass the kiosk. We also set up alerts in the EMR for athletic trainers to approve athlete treatment sign-in and write daily notes associated with the treatment. To implement our initiative and test our change, we completed the following PDSA cycle. We installed kiosks, educated the AT staff on their use, and began with a test pilot group of approximately 90 football athletes. We began having the athletes sign in through the kiosk in March of 2018. We then compared treatment data from March to May of 2018 to the previous year's data to see if an increase in treatments logged occurred. Although our pilot study did not present with a 25% increase in treatments logged, there was a small increase in treatments logged compared to the previous year. At this point, we decided to implement the plan with the remainder of the athletes on campus, with the added plan of the assigned team athletic trainer reminding the athletes to sign in prior to leaving. In order to spread our plan, we needed to get all the athletic training staff and athletes involved. At the weekly staff meeting following the PDSA study period, the director, associate director, and head football athletic trainer supplied the results of the PDSA to the athletic training staff. The importance of accurately documenting all patient treatments was discussed, and the AT staff was again educated on how to sign athletes up on the biometric sign-in and on the treatment sign-in procedures. The athletic training staff was then tasked with signing their respective athletic teams up for biometric sign-in and teaching the athletes the sign-in process. The AT staff was also asked to remind their athletes to sign in prior to leaving the athletic training room. The athletes were then responsible for signing in prior to leaving the athletic training room and also asked to help remind their fellow teammates to sign in before leaving the athletic training room. Quality improvement is a process that never stops. We continue to look monthly at reports to see where we can improve in our documentation strategies. As a staff, we know the importance of patient documentation and have seen multiple benefits because of improving our methods. As athletic trainers, we have a responsibility to diligently and precisely document patient care and improve our methods to address healthcare gaps and break through barriers that inhibit processes. Future quality improvement efforts should be directed individually throughout AT staffs and professionally to address gaps in documentation so our professional standards meet and then exceed those of other medical health professionals. Thank you for viewing this presentation. I have thoroughly enjoyed this class with all of you and hope to have another soon.